फ्रेंड्स, आज हम पढ़ने वाले हैं इंडोक्राइनोलॉजी इन रिलेशन टू रिप्रोडक्शन. The endocrine glands play a very important role in physiology of reproduction. Endocrinology in relation to reproduction includes the knowledge of hormones essential for maturation of the Graafian follicles, ovulation and maintenance of corpus luteum after fertilization. Following conception, transfer of function of pituitary ovarian axis of placenta, which acts temporarily as a new powerhouse or endocrine organ. Physiological alteration of various endocrine glands, namely the pituitary thyroid, parathyroid, adrenal and pancreas during pregnancy. Endocrine control of labor, this is discussed in chapter 13. Hormonal influence during prepurium, necessary for maintenance of lactation. Maturation of Graafian follicles and ovulation. The follicle maturation takes place during the first half the cycle. Hormones essential for follicle maturation are mainly FSH and a small proportion of LH. For continued FSH activity, estrogen is necessary. Ovulation under the influence FSH, about 20 Graafian follicles develop spontaneously and only one of them will be able to ovulate. The rest of become ultratic mix up with intestinal tissue. For the details, see author's textbook of gynecology chapter 8. Causes of ovulation. The possible factors involved in ovulation have been described on the chapter 17. Changes in follicular after ovulation. Maintenance of corpus luteum after fertilization. Placental endocrinology. Hormones of placenta. Protein hormones. Hormone chorionic gonadotropin. Functions. Human placental functions, growth factors, steroidal hormones. डायग्राम है फ्रेंड्स, देखिए. पेनक्रियाज. हार्मोनल इन्फ्लुएंस इन नेसेसरी फॉर मेंटेनेंस ऑफ लैक्टेशन. यह डायग्राम, ये फ्रेंड्स आप ज़रूर याद करिएगा क्योंकि ये भी इम्पॉर्टेंट है, ये भी आता है एग्ज़ाम में. ये छोटे छोटे जो दिए हैं फ्रेंड्स, छोटे छोटे टॉप समरी पॉइंट्स, इनको आप ज़रूर याद करिएगा, ये एग्ज़ाम में बिल्कुल आता है. अब आ गया है हमारा नेक्स्ट चैप्टर, डायग्नोसिस ऑफ प्रेगनेंसी. तो डायग्नोसिस ऑफ द वुमेन पीरियड ऑफ the reproductive period of a woman begins at menarche and ends in menopause. शुरू होता है महवारी से और अंत हो जाता है इसका मेनोपोज, मतलब कि एंड ऑफ मेंस्ट्रुएशन साइकिल. It is usually extend from 13 to 15 years. While biological variation may occur in different geological areas, pregnancy is rare below 12 years and beyond 50 years. एक महिला है लीना मेडिना in Lima, Peru, was youngest one delivery by cesarean section when she was only 5 years and 7 months old, and the oldest one at 57 years and 4 months old. Duration of pregnancy. The duration of pregnancy has traditionally been calculated by clinicians in terms of 10 lunar months or 9 calendrical months and 7 days or 280 days or 40 weeks. Calculated from the first day of the last menstrual period, this is called the menstrual or gestation age. But fertilization usually occur 14th days prior to the accepted missed period in a previously normal cycle of 28 days duration. It is about 40 14 days after the first day of the period. Thus, the true gestation period is to be calculated by subtracting 14 days from 280 days is 266 days. This is called fertilization or ovulatory age and is widely used by embryologists. First trimester, first 12 weeks. Subjective symptoms. The following are presumptive symptoms of early months of pregnancy. सब्जेक्टिव सिम्टम्स हैं पहले 12 वीक्स, जो पहला 12 सप्ताह होता है, मतलब 4 महीने जोड़कर करेंगे तो 4 महीने हो जाएंगे. तो एमेनोरिया is the subjective symptom. During the reproductive period is in otherwise healthy individual having previous normal periods likely to be pregnancy unless proved otherwise. However, cyclic bleeding may occur up to 12 weeks of pregnancy until the decidual race is bloodlet by. Bleeding is usually scanty, lasting for shorter duration, and then her usual and roughly corresponds with the date of the accepted period. This is termed as placental sign. This type of bleeding should not be confused with commonly met pathological bleeding. Treated abortion pregnancy, however, may occur in women who are previously anemic during lactation and puberty. Morning sickness, nausea and vomiting is the inconsistency present in about 70 cases, more than often in first pregnancy than in the subsequent one. It is usually appears soon following the mixed period and rarely lasts beyond 16 weeks. Its intensity varies from nausea on the rising from the bed to loss of appetite or even vomiting, but it usually not affect the health status of the mother. Frequency of micturition is a quite troublesome symptom during 8 to 12th week of pregnancies due to one resting of the bulky on the fundus of the bladder because suggested adverted position of the uterus, congestion of the bladder mucosa and change in the maternal osmoregulation causing increased thrust and polyuria. Thus, as a uterus strains up after 12th week, the symptoms disappears. Breast discomfort is the form of feeding of fullness and prickling sensation is evident as early as 6th 8th week, especially in pre-migrate date. Fatigue is a frequent symptom which may occur early in pregnancy. Objective symptoms of pregnancy are breast changes are valuable only in pre-gravidate. As a multigrade, the breasts are enlarged and often contain milk for years. The breast changes the evident 6th and 8th weeks. There is an enlargement with vascular enlargement evidenced by a delicate vein visible under the skin. The nipple and the areola primarily become more pigmented, especially in dark women. Momentary troubleness are prominent. Thick yellowish section cosium can be expressed as early as 12th week. Per abdomen, uterus remains a pelvic organ until 12th week. It may be just felt per abdomen as a subpubic bulge. Pelvic changes are diverse and appear at different periods. Collectively, these may be informative in arriving at a diagnosis of pregnancy. Jacquemus or Jadwick-Stein. It is the dusky hue of visible and interior vaginal wall visible at about 18th week of pregnancy. The discoloration is due to the vascular congestion. Vaginal sign Apart from bullish discoloration of the interior vaginal wall, the wall becomes softened, coefficient non-irritating mucus disc change appears at a sixth week, and there is increased pulsation felt through the lateral fornix at eighth week called Ocinder's sign, cervical signs. Cervix becomes soft as early sixth week, good wells sign. A little earlier in multi-pair, the pregnant cervix feels like the lips of the mouth, while in non-pregnant state like that of tip of the nose. On a speculum examination, the bullous discoloration of the cervix is visible is due to increased vascularity. Uterine signs, size and shape continuously. The uterus is enlarged to the size hence egg at 6th week, size of a cricket ball at 18th week, and size of a fetal head by 12th week, and pride from shape of 9 pregnant uterus become global by 12th week. There may be asymmetrical enlargement of uterus if there is a lateral implantation. This is called precursor sign, where one half is more firm than the other half. As the pregnancy advances, symmetry is restored. The pregnant uterus feels soft and elastic. Hager's sign. It is present in two-thirds of the cases. It can be demonstrated between 6th and 10th week. A little earlier in multi-pair, this sign is based on the fact upper part of the body of the uterus enlarged by growing fetus, lower part of the body empty and enlargedly softened, and the cervix is completely firm. Because of the variation in consequently, on binomial examination, two fingers is the anterior fornix and abdominal fingers behind the uterus. The abdominal and vaginal fingers seem to oppose between the body of the uterus. Examination must be figure number, this is the figure, demonstration of Hager's sign. Examination must be gentle, avoid the risk of abortion. Posterior palmar Palmer sign. Regular and rhythmic uterine contraction can be elicited during binomial examination as early as 4th 8th week. Palmer in 1949 first described it, and it available sign when elicited. Elicited the test, the uterus is cupped between the internal fingers and external fingers about 2-3 minutes. During contraction, the uterus become firm and well defined. During relaxation, becomes soft about 30 seconds with increasing duration of pregnancy. The relaxation phase increase after 10th week, and the relaxation phase is so much increased that the test is difficult to perform. Okay. Immunological test for diagnosis of pregnancy. Principle. Pregnancy test depends upon the detection of antigen present in the maternal uterine or the serum with antibody, either polyclonal or polyclonal level commercially. Agglutation inhibition test. Principle of agglutation inhibition test. Direct agglutation test. DCG direct test. Enzyme linked immunosorbent assay. Fibroimmunoassay. Immunoassay with radiotopes. Radioimmunoassay. Radioassay. Reduction of time. Other uses of pregnancy test. Second trimester, third, and ultrasound. Then second trimester, 13 to 28 weeks. subjective symptoms such nausea, vomiting, frequency of menstruation, usually upside will amenorrhea continues. The new features that appear quickling feeling of life denotes the perception of active fetal movements by a woman. It is usually felt 18th week, about 22 weeks earlier in multipary. Its appearance is a useful guide to calculate the accepted date of delivery with reasonable accuracy. See later in the chapter progressive enlargement of the lower abdomen by growing uterus. Journal examination. Closoma. Pigmentation over the forehead and cheek may appear at 24th week. Breast changes. Breasts are more enlarged with prominent veins under the skin. Secondary areola, especially demonstrated in premigres, usually appears at about 20th week. Monogometry tubercles are prominent and extend to the secondary areola. Colostrum becomes thick and yellowish by 16th week, and variable degree of strength may be visible with the advancing week. Abdominal examination. Inception. Linear pigmentation, linear nigra, extending from the apices pubis to aciform. Cartilage may be visible at early 20th week and steadily both thoroughly visible in the abdomen more toward flesh. Uh, Palpation. Fundal height is increased with progressive enlargement of the uterus. Proximity duration of the pregnancy can be ascertained by narrating the height of the uterus in relation to different levels in the abdomen. The following formula is an useful guide for the purpose. Palpation. The uterus feels soft and elastic and becomes ovoid shape. Uh, breaststroke, Hicks contraction are evident features of which have been mentioned. Palpation of fetal parts can be felt distinctly by 20th week, and finding are value not only to diagnose pregnancy but also to define the presentation and position of the fetus in later weeks. Active fetal movements can be felt at the interval, placing the hand over the uterus in early 20th week. It is not given positive evidence pregnancy but a live fetus. The pregnancy varies from infant fetal in early months to stronger movements in later months. External ballmate is usually 20 weeks when the fetus is smaller than the volume of the envelope. It is difficult in obstinate fashions, and in case of scanty liquid amyli, it is very association with the head and the fundus ejaculation. Sound is the most considerable clinical sign of pregnancy. Fetal heart sound. With an ordinaries can be detected in the 20th week. The resemble a trick of both under a pillow. It is varies with the position of the fetus and the rate from 110 to 160 beats per minute. The other sound are confused with fetal heart sound are those uterine shuffle is the soft blowing and systolic murmur. Heart is down at the site of uterus best on the left. The sound is a systematic with maternal pulses due to the increase in blood flow through the dilatation uterine vessels. It can be heard in big uterine fibroid. Fundic or fetal shuffle is due to rush of blood through the umbilical arteries. It is not a soft blowing murmur. Fetal sounds. Vaginal examination. The bluish dislocation of the vulva, vagina, or cervix is much more. So also softening of the cervix. Internal bromate can be irradiated between the 16th and 18th week. The fetus is too small before its 16th week, too large is placed 20th week. However, the test not be relictated cases the scanty liquid amini or when fetus is transferably placed. Investigation, imaging studies, sonography, fetal organ anatomy, magnetic resonance imaging, MRI, radiologic, MRI. Last trimester 29 to 40 weeks. Symptoms. Subjective symptoms are amenorrhea persist, enlargement of abdomen is progressive, which produces some mechanical discomfort to the patient, such as palpitation of or dysphagia following excretion, lightening about 38th week, especially in pregrative, a sense of relief of the pressure of the symptoms subdued due to enlargement of the presenting part, frequency of maturation appears, and fetal movements are more pronounced. Signs. Cutaneous changes are more prominent with increased pigmentation, and uterine shape is changed from cylindrical to spherical beyond 36th week. Fundal height. The distance between the umbilicals and the ensiform cartilage is divided into three equal parts. Fundal height and correspond to the section of the upper third to 32 weeks to up to the ensiform cartilage at 36th week, and it becomes down to 2 weeks level at 40th week. Because of the enlargement of the presenting part, they determine whether the height of the uterus correspond to 32 weeks or 40 weeks. Enlargement of the head should be tested. If head is floating, it is of 32 weeks pregnancy, and if the head is engaged, it is of 40 weeks pregnancy. Our next chapter is fetus in utero. Our next chapter is fetal skull and maternal pelvis. This is the fetal skull. This is the skull of fetus. The pelvis. This is the pelvis. This is maternal pelvis. Maternal pelvis. Antenatal care. Antenatal care. So systematic supervision of a woman during pregnancy is called antenatal care. Aims and objectives. The objective is ensure a normal pregnancy with delivery, a healthy baby from the healthy mother. Criteria of a healthy pregnancy or delivery of a single baby is good condition at the term between 38 to 42 with fetal weight is 2.5 kg or more than with a number of maternal complications such as normal pregnancy is procedure of a first visit of a woman. Procedure first delivery, antenatal advice to counsel the woman, diet, antenatal hygiene, bathing, clothing, the suits and belt, dental care, care of breast, courtiers, travel, smoking, alcohol, minor illness, pregnancy, value of normal. Antenatal assessment of fetal well-being. Prenatal genetic counseling, screening and diagnosis. Normal labor. Series of events take place in the genital organ in effort to expel the variable products of the conception, fetus, placenta, and membranes out of the womb through the vagina into the outer world is called labor. Delivery is the explosion or extraction of a variable fetus out of the womb. It is not synonymous with labor. Delivery can take place without labor, as in uh, elective region section. Delivery may be vaginal, either spontaneous or aided, or it may be abdominal. Normal labor. Eutrosia labor is normal if fulfills the following criteria: spontaneous in onset at the term with the vertex presentation, undue progression, nor natural termination with minimal aids without having any complication affecting the health of the mother and or baby. Abnormal labor dystocia. Any deviation from the definition of labor, normal labor is called abnormal labor. Causes of onset of labor. Physiology of normal labor. During the pregnancy is marked atrophy and the hyperplasia uterine muscles and enlargement of the uterus at the term left. The uterus measures about 35 centimeter, including cervix. The fundus is divided both transversely and anteroversely under the lower segment, and the uterus assumes periforms and ovoid shape. Causes the underregulated by the mucus plug. Events in the first stage of labor. The first stage chiefly concerned with the preparation of the both canals, so it is facilitate expulsion of the fetus in the second stage. The behavior that occurs in the first stage are dilatation and effacement of the cervix and full formation of lower uterine segment. Dilatation of the cervix prior to the onset of the labor, it is the pre-labor phase. There may be a certain amount of dilatation of cervix, especially in multipary and in some pre-gravid important structures components of the cervix, smooth muscles, 5 to 20 collagen and ground substance, predispositing factors which fever, smooth dilatation, softening of the cervix, fibromuscular atrophy, increased vascularity, accumulation of fluid in between collagen fibers, breaking down of collagen fibers by enzymes, collagen and elastic, and change in the various glycosaminoglycans, increase in hyaluronic acid, decrease in dermatan folate in matrix of the cervix. Cervix. These are under action of hormone estrogen, progesterone, relaxing too much fibrosis in chronic cellulitis or prolapse of the organic lesion in cervix, and carcinoma results in deficiency of the factor. As a result of cervix may fail to dilate. Actual factors are responsible for uterine contraction and retraction, fetal excess pressure, bag of membrane. Via trago. Events in second stage of labor. The second stage begins with the complete dilatation of the cervix and ends in the explosion of the fetus. The stage is concerned with the recent delivery of the fetus to the childbirth. Explosive from full direction until the head touches the pelvic floor. Explosive since the time mother has irresistible desire to bear down and push until the baby is delivered. With the full dilatation of the cervix, the membrane usually rupture. There is escape of good amount of liquid anine. The volume of the uterine cavity is thereby reduced spontaneously. Uterine contraction and retraction become stronger. The uterus become elongated during contraction, while the anterior, posterior, and transverse diameter are reduced, and elongation is partly due to the contraction of the muscular muscle fibers of the uterus to keep the fetal axis straight. The exclusive force of uterine contraction. The events uh, in third stage of labor. The third stage of labor comprises the phase of placental separation. It is descent to the lower segment and finally it explosion with the membranes. Placental separation at the beginning of the labor. The placenta attachment lovely correspond to an area of 20 centimeter 8 in diameter. There is no perceivable devastation of the surface area of the placenta attachment during the first. During the second, there is a silent but progressive dilatation of the area following successive detail which attains the peak immediately following the birth of the child. After the birth of the baby, the uterus measures about 20 centimeter 8 vertical and 10 centimeter 4 and posteriorly the shape becomes discoid The wall of the upper segment is much thicker uh, while the hubby or segment is thrown into the folds. The cavity is much more reduced and accumulated only after mechanism of the separation. Central separation, margin separation. Marked retention reduces effectively surface the surface of area placenta due to about as half, but the placenta is inelastic, is not keep the pace in extent amortization, resulting in the area strain force induced between the placenta and the placental side, which brings about its ultimate separation. The placental separation runs through deep spongy layer of the residua basilis, so that the variable thickness of residua covers the maternal surface of the separated placenta. There is two ways of separation of placenta: central separation, marginal separation. Detachment of the placenta from its uterine starts from the central, resulting in opening up of the few uterine sinus and accumulation of the blood behind the placenta, and with the increasing consumption more of the detachment of the flaccidated weight with the placenta and retroplacental blood until whole of the placenta get detached. Separation starts from the margin is mostly supported with progressive uterine contraction, and more areas of the placenta get separated. Marginal separation is found more frequently. Separation of the membrane which are attached loosely inactive, the thrown into multiple folds. Those attached to lower segment are already separated during stretching. The separation is facilitated partly the uterine contraction is mostly by weight of placenta and is descend down from the active part, and the membrane so separated carry with the remnant of decidua where giving the outer surface of chorion its characteristic roughness. Explosion of placenta. After complete separation of the placenta, it is forcedly down into the lower uterine segment or upper part of the vagina by effective contraction retraction of the uterus. Thereafter, it is expelled out either by voluntary contraction of abdominal muscles bearing down effects or by manual considering mechanism of the control of bleeding. After placenta separation, immunological round sinus which have been circulation of the blood from the uterine ovarian vessels have to be obliterated. The occlusion is affected by the complete retraction by their arterioles as they pass through the interlacting intermediate layer of the myometrium. The literally come to its principal mechanism of hemostasis. However, the thrombosis occurs occlude in thrown sinus, a phenomena which is facilitated by hypercoagulable state of pregnancy, apogeiation of walls of the uterus following expulsion of the placenta. Myometrode also contribute to minimize blood loss. Mechanism of normal labor. The series of movement that occurs on the head in the process of adaptation during its journey through the pelvis is called mechanism of labor. Chart number mechanism of labor. Second stage begins with the full dilatation of the cervix and ends with explosion of the fetus. Pain. The intensity of the pain increases. The pain comes at an interval of 2-3 minutes and lasts about for 1.5 minutes. It's become successive with increasing intensity in the second stage. Bearing down efforts. It is involuntary ovulatory expulsive efforts that appear during the second stage of the labor. Membrane status. Membrane may ruptures with the course of the descent of the fetus. Clinical course of third stage of labor. The third stage includes separation, descent, and expulsion of the placenta with its membrane. Pain for a short time. Patient experience no pain, however, intermediate discomfort in the lower abdomen disappears, corresponding with uterine contractions before separation. Per abdominal uterus become discoid in shape. Limb in fetal and normal funnel height reaches the silently. Per vaginum. After separation. Per abdomen. Place of delivery. Management of normal labor. General consideration. Normal labor has got great physiological, emotional, and social impact. Woman or family, she experiences stress, physiological pain, and fear of danger.